Thank you very much, Madam Chairperson. Distinguished guests, colleagues, it's an honour for me to participate in this important discussion, occurring at such a critical time in the history of global public health. The Millennium Development Goals have captured the imagination of people from all walks of life, from heads of state to school children around the world. Last month, we released the State of the World's Children for 2009. Enclosed within its pages are the official statistics on global health from around the world. Some tell a story of dramatic, albeit insufficient, progress. In 1960, more than 20 million children under 5 died every year. In 2007, the number is close to 9 million, less than half. Bill Gates has described this figure recently as one of the most amazing statistics ever. And yet, the State of the World's Children this year, dedicated to the issue of maternal and newborn health, tells another, more tragic story. Every year, as has been mentioned, 500,000 women die from causes related to pregnancy and childbirth. Over 99% of these deaths occur in developing countries. In what is often described as the greatest health disparity in the world, a woman from Niger faces a lifetime risk of dying due to pregnancy of 1 in 7. Think about that, 1 in 7. And then compare it to Ireland, the safest place in the world to deliver a baby, where the risk is around 1 in 48,000. While some progress has been made in improving access to skilled providers at birth, a staggering 50 million of the 135 million births that occur every year are not attended by a skilled provider. And of course, the consequences go beyond the direct effects on maternal health. Of the 9 million deaths among children under 5, around 40% occur in the first 30 days of life, the newborn period. There is an increasing recognition of the inextricable relationship between maternal and newborn health. You may be familiar with some of the numbers I've just cited. One of the other critical numbers, however, is less well known. Of the 500,000 women that die every year, 70,000 are girls aged 15 to 19 years. Early marriage and early pregnancy remain critical factors for maternal death. In addition, despite some positive trends in HIV prevalence in sub-Saharan Africa, girls and young women remain extremely vulnerable. In Southern Africa, adolescent women are between 2 and 4.5 times more likely to be infected than men of the same age. In one country, Swaziland, HIV prevalence is 23% in young women aged 15 to 24 and 6% for men in the same age group. Sexual violence against girls is all too common in such settings, as well as in conflict-affected countries. It's clear that some of these solutions to these problems can be found in the health sector. The combination of family planning, good antenatal care, including adequate nutrition, and integrated prevention of maternal-to-child transmission for HIV. Skilled birth attendants and access to emergency obstetric care, as well as postpartum and newborn care, including a focus on early and exclusive breastfeeding, can all make a significant difference. Indeed, the best indicator of the overall performance of the health system may in fact be maternal and child health indicators. And yet, it's also abundantly clear that many of the solutions lie beyond the health sector. How can a woman who is illiterate or has no control over her household finances be assured of being able to recognize the complications of childbirth and then access transportation required to get to a facility if she suffers complications of pregnancy? Educating girls and young women, protecting their rights and empowering them will be critical if we are to break this vicious cycle of gender discrimination, poverty, and high rates of maternal and newborn mortality. So where does the philanthropic and private sector fit into this discussion? Well, we must start by acknowledging the contribution the private sector is already making and has made in nutrition, water and sanitation, HIV, malaria, and immunization. UNICEF is proud to be collaborating with more than 600 private sector companies and foundations across the globe. It's a pleasure to see many of the partners here today: Becton Dickinson & Co., IKEA, Merck, Pfizer, Football Club Barcelona, and Gucci. As globalization and new information technologies are transforming societies, public and private sectors are becoming more interdependent. We have witnessed, for example, how your interests have grown from traditional philanthropic donations to more comprehensive strategic social investments that obtain measurable results and affect lasting change. Given the enormous scope of the problems, however, what we believe is required is a step change in the order of magnitude of these partnerships. The type of step change that was announced today with the IKEA support to UNICEF's child survival program in India of around $48 million US. At the global level, we see two important new models for private sector engagement that can help make this step change from an incremental, company-by-company, project-by-project approach to that of a global program with global scale and the potential for truly global impact. The first is the model provided by the Global Business Coalition for HIV/AIDS, TB and malaria, or other advocacy coalitions such as Malaria No More. Such coalitions have helped to transform the visibility of global health at the highest political and executive levels. The second model is that of innovative financing, and I'm sure my colleague Julian Love-Levitt from Gavi will also mention this. The Affordable Medicines Facility for Malaria, a partnership with the Global Fund, is a good example of how a public-private partnership may help to transform access in poor countries to highly subsidized drugs, in this case artemisinin-based combination therapies, through the private sector. The Advanced Market Commitment for Pneumococcal Vaccine is another example of a public-private collaboration with the potential to transform our ability to reach, in this case, MDG4. However, perhaps even more important is the need for us to work together in a more coordinated and systematic way at the country level. Let's remember, 2/3 of all maternal deaths occur in just 10 countries. Let's work together to prioritize our collective actions in such countries. Our UNICEF office in Kenya, for example, working closely with the private sector, has helped develop a conceptual framework for collaborative action called the Partnership Ladder. The ladder summarizes the different degrees of corporate engagement, from product sales to in-kind assistance, to campaign donations, to program funding, to using technology and market networks, to expanding strategic giving for children, to creating family-friendly workplaces, and finally, and most importantly, to influencing national laws and policies. We need to work more systematically together to create such strategic country-based alliances, based on the relative core competencies and comparative advantages of all partners, so as to achieve the MDGs. Finally, as the world's attention is focused on the financial crisis, I think it's important to recognize that financial barriers, including user fees and other out-of-pocket payments, pose a significant obstacle to women and children obtaining life-saving care. In many countries, payments associated with accessing emergency obstetric care, such as caesarean section, are prohibitively high and a major cause of impoverishment. Basic primary health care is therefore a critical pro-poor measure for social protection. So now is not the time to cut back on such programs. It is precisely the time to invest in them. Let us today make a joint call to action for a long-term investment in these strategies to protect the most vulnerable. There are few investments in development for which we can measure impact so directly in units of lives saved and lives improved. Thank you.